Morning, everybody. So, as Glenn says, my role is I'm professional lead for hospital pharmacy. So I'm actually here talking partly as a stand-in. So I clearly didn't duck when I saw Glenn's phone call at 7 o'clock in the evening a couple of days ago to come and do this. My colleague, Keith Farrer, who's the Senior Responsible Officer at NHS England, is unable to be here to present it today. But it's an area that I've had quite a significant involvement with over quite a few years. So I wanted to sort of cover some of the basics and the information around the Falsified Medicines Directive, and I want to then also link with the previous presentation and the subsequent presentation, because it's all about interoperability and it's all about data. So for those of you who aren't indoctrinated into the world of pharmacy, I know there are a number of colleagues around the room who are well aware of pharmacy, but the issue about fake medicines, and this is proper fake things, this isn't fake news and things like that, this is actually proper fake information. And these are medicines that aren't real or as authorized. And they might contain ingredients that aren't active, are the wrong strength, or aren't even the active ingredients contained within them. Or they might not be a pharmaceutical grade made in a factory somewhere where they're not authorized to make medicines. And has been seen for quite a few years as being a major threat to public health. It's a major threat to the commercial side of the world as well, because of companies being defrauded out of their products. But also you can't miss on the news the number of seizures. I think the headline is it's always about Viagra and things like that end up being in the headlines, but there's an awful lot of medicines, particularly with the internet and the globalization and the little packages that come in because they bought it from somewhere, and it's, be it a diet pill or whatever. So it is a significant threat. So the Falsified Medicines Directive, 2011, and it specifies a range of safety features. And it isn't just about coding. It isn't just about barcodes. It's about safety features to make medicines safer. And it's to make sure that the regulators and the users and the teams who have to manage medicines are able to control the use of those medicines. And it's very specific. It applies to all prescription-only medicines. It only will apply to one of the over-the-counter and pharmacy-type medicines, which has a particular problem with counterfeiting. But at the moment, it is intended to only impact on prescription-only medicines. And it will impact on all organizations who supply these medicines, be that a manufacturer, be it a wholesaler, or be it the pharmacy or dispensing doctor who actually supplies those medicines. Healthcare institutions, as in hospitals, are required to decommission medicines from the supply chain. And there are exclusions about those organizations which aren't healthcare institutions. So things like dentists, seen as healthcare institutions, such as dentists, oil rigs, things like that are excluded from the regulations within Article 23, which will allow somebody else to decommission for them. As I say, it is prescription-only medicine, so we just need to keep focused on that. So that presents an interesting challenge when you've got a hospital pharmacy that has lots of medicines coming in. Not all are prescription-only medicines, and they're going into standardized robots or ward storage cabinets, but they have different coding on them because they don't have the unique identifier that falsified medicines requires. So you have to have systems that can deal with that, and that is going to be an interesting challenge in the next 15 months, Glenn. So the rules laid down the safety features that were required to appear on packaging. So the safety features might include tamper evidence. So that might show that you've opened it. It might be something really simple like a paper engineering type one, or it might be hologram labels or seals to show that something's been tampered with. And then it includes a unique identifier. And if you've been to Boots, for example, you'll see that some of the over-counter products that generics from India already have the barcodes on. This is an immunoglobulin which is already starting to have the codes included on it for track and traceability. So it's happening already. We've got a long way to go, though. And just to give you an indication of who's got different roles and responsibilities around this whole piece of work, lots of different people sort of have regulatory and system involvement. So Department of Health, MHRA, Secure Med, which I'll come on to in a moment, and then Avato, which I'll also describe. So DH is what is called the National Competent Authority, working with the MHRA to actually deliver that responsibility for the UK. And this is UK-wide, it's not England, it is UK-wide. And SecureMed is the not-for-profit organisation that has been created to be the legal entity for the National Medicines Certification Organisation. It's a bit sort of acronym soup, all of these things. There's a lot of acronyms involved in the whole falsified FMD space. It's funded by the pharmaceutical industry, and it's supervised by the Department of Health and the MHRA. And Novarto is the company that has been awarded the contract for operating the National Medicines Verification System. They're a German company, and they've already got experience implementing. So there's lots of information available, and I'm not going to get into any level of detail that colleagues from SecureMed could go into. Just in terms of how it works, and this is where you get into the acronym soup. So you've got people who hold manufacturing authorizations, you've got pharmacy distributors, you have a European hub, which is the Europe-wide verification organization, that then transfer information to the local country-based system, and that is, as I say, going to be held in a national repository by Novarto. But you then have the different connections, be that a wholesaler, who are the MHRA-authorized people who can supply medicines. You might have a hospital, or you then have the community pharmacies and the hospital pharmacies who then decommission the product using the barcode and the unique identifier. And there will be an opportunity then for reports from that national system. This is really important to say this does not capture patient detail. There is nothing about the patient. It is about confirming that the product is not counterfeit. So there is no data transferred that involves the patient. Coming back to interoperability, we saw the little images that are GS1 ones from a few years ago, and I'm not going to go into this. This is a presentation I did to a previous conference here, but I've been working on this with Glenn and with Neil Piper and others since 2012, so we have been doing lots of work. But what I've got is a summary of what the potential opportunities for having the falsified medicines code, a unique identifier, batch number, expiry on each product. And from a hospital point of view, yes, it's really good to have the assurance that it's not a counterfeit medicine. There are ancillary benefits from having the coding, and it will, people in this room are going to be well aware of some of these things. You've got improved management of products. Expiry date. If you've got the expiry date, you can make sure instead of having first in, first out in a robot, you can have the one that's the shortest expiry date, so you're not adding to waste. You can track and trace items from automated storage to a patient. You can control the recalls, etc., as it's already been alluded to. From a pharmacy point of view, as described on the film from Derby, you've got the opportunity for closed-loop checking, so that you know that you've got the right product and the right strength and connect to a smart pump or to whatever other system. A pharmacy thing is an opportunity for looking at how we cost home care. The NHS spends about £1.4 billion on medicines that are supplied direct to patients' homes. We need to know that those have been delivered. We need to know where the right product has got to the patient. So having a unique identifier can be used to help recharge and track and trace that. Massive piece, secondary uses of data. Keith, who is the SRO, is part of a NHS digital program on digital medicines, and one of the key work streams of that is secondary uses of data. And all of this coding gives us the opportunity to use data in a much better way. We've got the opportunity for using the code, so that might be the scanners on the wards to allow patients to be scanned, but also mobile phones, ubiquitous. You can scan your mobile phone with the drug and then be able to get an enhanced patient safety leaflet, or a simplified version of a patient leaflet, or a video on how to use your inhaler, because you've got that unique identifier and can track it. A relatively small one, but a massive piece of work in NHS hospitals is about controlled drugs. These are the drugs that have to be captured in terms of every transaction, and a running record kept on every single ward and department and pharmacy that use them. There's a huge opportunity for being able to have a unique ID on every single controlled drug. That means you can track where that goes. And then, in the unfortunate case where stuff does appear down on a nightclub or wherever it might appear outside where it should be, you can then trace it back to where it came from, and it will help manage that. Again, headlines. Opioids, quite a significant issue. Certainly coming from the States, lots of deaths associated with misuse of opioid drugs, and this might help with that. We do have some challenges. Timescales, more than 20,000 different sites, locations, systems impacted. 15 months, and there's, training all the people who work in those sites, the hardware need. It still hasn't been sorted in terms of what is necessary. And there are massive challenges about getting the software changes done to support, be it a BD robot that in a pharmacy department, or be it a pharmacy IT system that allows you to streamline the decommissioning process. Linking the product identifier and the product descriptor, and this is one I know GS1 are quite aware of, but there are still some challenges about how people use the standard codes. As an example, what do you scan? This is product, so which are the barcodes? And if you've got an automated system, it gets completely confused by this. So we have to ensure that regulatory side of things influence more than marketing side of things to get the barcodes right. So we've had some challenges where the marketing people have decided it's purple, we want purple, but then the scanners don't read the purple, or things like that. We have to make sure that it's seen as a really important, and it's incredibly essential for patient safety that we get the coding correct. There is a time impact. No matter how quick the specification is, there is an action of scanning something, waiting, dealing with the message if there is a message comes back, because if you think, going back, prescription-only medicines, so a junior or a band 2 dispenser might think, oh, I've got to scan this. They don't realize that it's not a prescription-only medicine because they haven't looked, they scan it. They didn't get a message saying not authorized. They have to then be trained and understand how to manage that. So it could add time, particularly when IT fails or the network goes down or somebody digs through your cable into the hospital so you don't have a network connection. So we have to have all of those things sorted. And again, my focus is hospital, but one of the real challenges is about when you're looking at bulk items. So if you look at a normal hospital, you've got an amount that goes through the dispensary, has a label stuck on it, goes out for a patient to be discharged. That's a small amount. If you then look at what comes out of the robot in terms of the ward stock, that's a huge amount, and you want to be able to automate that process. And part of my normal life is working with the Lord Carter Programme and Operational Productivity about how we transform the supply chain in hospital pharmacy. And so we're now looking at parts of the country centralising stores that supply direct to a ward. So these are going to be a separate legal entity which can't decommission, that are going to then be booking out and sending, hopefully, some sort of file to a hospital who can then decommission on bulk rather than having to have a big list and sort of do them individually. We have to get better at that, and there are significant opportunities for software systems to support that. So the current status, the B word, the intention is we don't want to end up being where any of these counterfeits turn up because we don't have a verification system. We have to comply with it. I know colleagues at MHRA and DH, conversations are ongoing with Europe about how that happens and going forward. It'll all be part of those discussions. SecureMed are working very closely, and they have had to focus on manufacturers, wholesalers, and community pharmacies to start with. And there is a gap at the moment in terms of secondary care about trying to really take it forward in secondary care, and that is something that is being scoped up to try and take forward by NHS Digital. But for trusts, we have a series of frequently asked questions that are going to be coming out next week because nature abhors a vacuum, and so there's lots of misinformation, disinformation, stuff flying around it. Nurses have to do this, nurses have to do that, or you have to decommission everything as it comes in the department. We're trying to help people with some FAQs while the process continues to identify what needs to happen in hospitals. So NHS Digital are working alongside the DH, MHRA and SecureMed to scope out that end-to-end implementation. It is very late, but it's part of the nature of the impact of Brexit, part of the nature of the whole consultation process on the falsified medicines implementation. So we are where we are, and we're still working to the February deadline. And coming back in my loop to the whole reason for doing this, it's the benefits of data, data, data. We need data to do, we need data from e-prescribing systems. We need to know the spend. The NHS still doesn't know exactly how much it spends on medicines. It doesn't know. There's a report that came out yesterday from NHS Digital, which gives list price for hospitals, it gives actual price for community pharmacy, but we do not have an exact number. finance colleagues, if there are any left in the room, sort of the whole cost improvement program, the whole need to look at NHS improvement, are doing a lot of work about identifying top 10 medicines and savings from those medicines. We need data. Bob mentioned the tariff. We need better data to inform the reference costs and the calculations and the costing transformation program that is going on to support future tariffs and how we are paid for things. And the real passionate bit from my point of view, and it's something that we call in the pharmacy world medicines optimization, is we can shovel as many medicines out and into people and get them to take things, or mostly 50% of patients don't take them as they're intended. But we need to know if there's a benefit from doing that. We don't need to keep giving those medicines. If they're not helping anybody, it's just a waste of time and money. And we know that, there was a headline from Scotland probably 2 weeks ago about a couple who moved into a brand new house, or into a new house, and opened the loft and found hundreds of bags of medicines that the previous person had kept getting from their community pharmacy, just put them in the loft. That's not a good use of the NHS limited resources. And then we've also mentioned the research and the need for things like genomic medicines and personalized medicines. So really useful document. If you haven't read it, sort of Life Sciences Industrial Strategy, really pushes for e-prescribing in hospitals, but then really pushes about how we better use this data. And we have to capture the data at a patient level. GS1 is the way to do that. And it's clear from Derby and from the other exemplar sites that this is something that will help feed into strategies like this.